with some of it. So we'll start off by going back to the standard echo views. Okay, I know that we covered these last quarter, so it should be a bit of a review at least. So these are the standard windows that we have for our echo this quarter. So again, we're going to get all the basic views. We're going to look at all the valves. We're going to look at the walls, the chamber sizes. Going to do a bunch of measurements. So today I kind of want to talk about the echocardiogram, what we're looking for, what we measure, all that kind of stuff. So first thing is knowing the anatomy is going to be the most important part. So anybody want to label?
Ed does.
All right, go for it. You learn better by hands-on doing it, so we'll walk through it together. Probably use these markers up here better. The red one I don't think shows up very well, so maybe try one of the other ones, blue or black or something's fine. All right, so what are we looking at? So let's first go and label the views. So what are they? So peristernal long axis, so PLAX is how we abbreviate it.
You want to do all the views?
Yeah, let's do all the views. So there's short axis, PSAX. Just be aware that when you're out in clinical setting, go ahead and keep labeling. When you're in a clinical setting, calling it by plaques or PSAX or something like that, they may have no freaking clue what you're talking about. So it's appropriate to call it peristernal long axis. We just abbreviate it for abbreviation's sake.
How come they didn't have the apical 3 chamber in here?
Apical 3 in where? Which one is that? Is that the
Fagin-Bombs. I didn't see it. I was really confused.
Yeah, I don't know why it wouldn't be in there. It should be in there. They may call it apical long axis. So some of the terminology may be slightly different. So an apical 3 chamber is the same as an apical long axis. And apical 5 chamber is the same as saying, in fact, the new terminology they're trying to push to say it's an apical 4 chamber with aorta, because aorta technically is not a chamber. So semantics. Don't get thrown by the fact that somebody says go to 5 chamber, go to 3 chamber. That's what they're looking for. Okay. So that might be partly why, but it would surprise me that they wouldn't have it in there.
There is a long axis, but it's not like, just wasn't how they presented the other views. Like,
Okay.
it wasn't as prominent, I guess.
Okay. So what's going to be important now is labeling the anatomy of it. So what are we seeing? So we'll start with peristernal long axis. It's our first view that we do. There's a ton of stuff we do on it. So we're going to start, right ventricle is the chamber, left ventricle, look at the valves. So now that we're looking at the valves, it's not any longer for us going to be just, hey, this is mitral valve, this is aortic valve. I want to know the cusps of the valves. I want to know which leaflets we're looking at, all that. So on this one, so doing a great job there. So we got right ventricle, left ventricle, mitral valve, aortic valve, left atria, coronary sinus at the back. And I'm drawing kind of some extra stuff in there because you kind of want to be aware of what's around the heart also. We've got our descending thoracic aorta, which is going to be seen there. I didn't draw it in all the images, but be aware that you might see them in the images. Good, so let's look at the leaflets real quick on that view. Aortic valve, so starting at the top where the transducer is, where's our transducer in that?
It's on top.
Oh yeah, it's like this.
Yes. So my transducer is assumed in all of these pictures, the way I've drawn them, to be directly above the heart. Okay. We can see different views, like when we get to some of these short axis, for example, when we're looking at some of these from subcostal, it's going to look identical to these, it's just twisted differently. Okay, so it's important to kind of understand what we're looking at there. So we're not going to go over wall segments yet. We are going to get to that in stress echo, but it's really important that you understand the 16 or the 17 wall segments that we have. Part of those segments is the septum. So where is the interventricular septum in this?
Right there. Yeah.
Right in that area, good. So we need to be able to evaluate that. So the septum actually has different components to it in the 17 wall segments. In the wall segments we have levels. So we've got the base, which is going to be close to the valves, the mid portion, and the apical portion. So when we draw out the 17 segments, we're going to have to distinguish those. In the septum, the septum's going to divide us, we're going to divide kind of across like this. This is going to be inferior septum, that's going to be anterior septum. So it's either going to be, this level is base, it's around the mitral valve, but I'm seeing the base of the muscle. So this is going to be, for example, anterior, the base anterior septal wall. This is going to be the inferior septal wall at the base. This is going to be anterior septal wall mid. This is going to be inferior septal wall mid. And then apex only has 4 segments, but that's kind of how we're going to divide things up. So it's important you know where the septum is on these. Just as a question, so if I was to label a wall out here, what do you think that wall might be? So we're at the base section, but as far as anterior or inferior, and how do you tell? Because our transducer's up here, this is the anterior wall, this is the inferior wall, so this is actually inferior wall. If I'm slicing through this, right at this section, is that a septal wall? It can't be because it's not between the ventricles, right? So those things are going to be, your landmarks are going to be really important to understanding what you're seeing. And when we're scanning these, we want to detail that as much as possible. Good, so let's go to the aortic valve then on the peristernal long axis view. So we've got 3 cusps. From your reading, what do you know that we see from peristernal long axis? Or even guess?
Right.
Okay, so we have 3 cusps. We have right coronary cusp, we have left coronary cusp, and we have non-coronary cusp. Why do they call it a coronary cusp?
Coronary artery comes out.
Because a coronary artery comes out behind it in the sinus of Valsalva. Sinus of Valsalva is kind of the outpouching after the valve. And that's where the ostia, or the opening of the coronary arteries are. So the top one is actually,
Could it be non?
the top one is the right coronary cusp. That's the first one you're going to hit. That's the most anterior leaflet in the aortic valve. Okay, so you're going to want to know those and memorize them. In peristernal long axis view, we never see, or you should not see, the left coronary cusp. So the other one is the non-coronary cusp. Okay, so that's going to be important. Which leaflet on the mitral valve comes first anteriorly? What's the most anterior leaflet in the mitral valve?
Is it the anterior?
The anterior leaflet. And then the posterior leaflet is the posterior one. Good. So know those. So peristernal long axis view, that's what we're seeing. I don't get as concerned about leaflets on the tricuspid valve or the pulmonary valve, but you definitely want to know the aortic valve and the mitral valve in all your views, and what leaflets we're seeing. In fact, on the mitral valve, we're going to get into the scallops of the leaflets, which is a segment of each leaflet, because that becomes important as we get into regurgitations and stuff like that and fixing the valve. Okay. Other than that, we've got some walls and stuff. We'll get into wall segments a little bit later. If we've got some time today or this week, maybe we'll go over the wall segments individually. Because if you understand wall segments, you'll understand how to get your views better. If you're just kind of going arbitrarily looking for a view that looks something like what I drew on the board, you might be okay, but the key is getting the right walls in at the right times, and these views are coordinated with those wall segments. Okay, next view down, so that's, we'll just kind of go with our protocol. So we're scanning, we do the peristernal long axis view, then our next view from there is what? So how first of all, do we orient ourselves on peristernal long axis? If you've not printed it out yet, in the resources under the modules, I have a document, I forget what the document name is, but it looks like this. So it's got the pictures of the slices there. So on this, it's got the sectors that are drawn over it, but pay very close attention to where the sector is. This is parasternal long axis. So you're going to get to some others like this. This can look like a two-chamber view, but it's actually the right ventricle. So you're going to notice that the sector is coming from a different position than it would be for this two-chamber view. This two-chamber view, the sector should be directly above the apex. Okay? Whereas that two-chamber view, it's going to be offset. That's a right ventricle, this is a left ventricle, very different anatomy. So it tells you the anatomy that you should see on this. It tells you the transducer location, so this is going to be parasternal in this area, and it's going to tell you where the index marker should be pointing for every single view. So you want to print this document out and kind of go through it. There's an anatomy assignment as well. I used to grade it. I don't think I'm going to grade it this year, but I want you to take that and go through as best you can to label the anatomy so that you get in your mind the anatomy orientation. But this document should be helpful to go over that. Another helpful website is echobasics.de. Okay, I think it's from Denmark, but it's actually a good view. It goes over the same stuff, but it gives you actual echo views that you can take a look at, like clips and stuff like that, where you can go and look and see the anatomy and things like that. And it will also give descriptions of where the indicator should point and how you should be oriented. Fundamentally, right now, that we have to get down. Okay. It's going to be very important for lab. So continuing on, so the next view then is, this is our tricuspid valve view. So what are we seeing in the tricuspid valve view? You see right ventricle, tricuspid valve, and right atria. Okay? So we could get into the leaflets. That anatomy assignment actually does go over some detail on leaflets. I'm not going to be super concerned about it. You have 3 leaflets on the tricuspid valve. We have a septal leaflet, and then we have an anterior and a posterior leaflet. They're different sizes. You know, like the aortic valve cuffs are all the same size. The pulmonary are the same size. The mitral valve have different size cusps, and so does the tricuspid valve. Tricuspid valve is the biggest valve. Area-wise, and it's you know, it gets leaky. It's also the lowest pressure chamber of the 2 chambers relatively, and so they get a lot of leakiness and stuff because it's so big and floppy and low pressure. And we'll deal with that when we get to some pathological stuff. So where the tricuspid valve dumps into the right ventricle, do you think that is an outflow or an inflow? You're talking relative to the ventricle. It's the inflow. So when we talk about this, we're going to use the terms interchangeably. So this could be called, yeah, the IVRT or RVOT. It's going to be the outflow. Good. So this is not going to be RVOT there, though. I'll erase that. So we're just going to be talking about it relative to the ventricle. So that's tricuspid valve. How do we find the tricuspid valve from our parasternal long axis view? By sweeping again like a broom, you're fanning the sector, kind of like this. So this is our handy little thing. So if you want to get one of these and paint a side of it, this is your indicator side. This is our transducer. We're about rib space 3. So we're angled like this. All references to the heart are in length of the heart, like reference to the maximum long axis of the heart. So we don't do sagittal on the heart, we do long axis, because this is very oblique on the body, but it's long axis to the heart. And then when we talk about short axis, we are 90 degrees to that longest axis. Okay, so when we talk about referencing the heart, it's all in relation to the heart itself, not the body. We'll kind of give some allusion to the body, but you have to understand that we're doing everything in conjunction with what direction that heart is going. So indicator up to the right shoulder. Tricuspid valve, we're pointing down towards the valve. Okay, so we're going from the aorta down to the valve there, and that's where we get this view. And then the next view is what?
Pulmonary.
So that's the pulmonary valve we're going for. Okay. And then on top of that, so I'm drawing in the muscle a little bit thicker as well, so you kind of clue in that this is muscle, it's thicker, that's not an vessel, it's the muscle of the wall. So that's right ventricle there. And I drew in the left ventricle. I don't always draw that in, but the left ventricle, you have to be aware, is right beside it. So if you have that open, there could be shunts going across here. So if the heart doesn't form correctly and they've got a hole in the heart, that could be happening here. We need to be able to see that area. So when we do Dopplers and we do evaluations of these valves and the structures, part of what we're looking at is to see that there's a separation of flow between those things. If there's not a separation of flow and we have a shunt, that's a problem, and we need to document that appropriately. So we've got the pulmonary valve. What sits beyond the pulmonary valve? Pulmonary artery. Okay. So what's another name then for this area coming from the ventricle out the pulmonary valve? So that was RVIT.
Outflow tract.
So this is the outflow tract. So this is the RVOT. Okay. This is actually where we take the pulsed wave when we're doing pulmonary valve study. We take the pulsed wave just before the valve. This is range specific. If I put continuous wave through there, what's the problem with that? It's not depth specific, so if I'm looking for just the flow right there, I need to know what that flow is. So the pulsed wave gives us a range specific spot, and we're going to measure the acceleration time on this. Okay. Again, I'll reiterate, the resource under the modules in Canvas has all these documents. Go through those documents because it's going to help you understand where to measure things, what the timing of the measurements are. There's a set of PowerPoints that I created that shows you how to measure it, both Doppler waveforms and the walls and everything else. We'll kind of go over some of it today, but that's your resource to go back to. Keep note that if you go through it on Canvas, you're just going to see the pictures of the slides. There's notes on those slides as well, so you might want to download it and see the notes section as well, because it tells you all the intricacies about those. Okay, so that's where we pulse wave, that's where we're going to take our acceleration time, and then we continuous wave through the valve because we want to get the highest velocity. Why do you think the highest velocity would be through the valve and not, say, in the RVOT or even in the pulmonary artery?
We decrease the area.
Yeah, so we've got this tubular shape. It's kind of conforming like this, and then it comes in a tubular shape. That's going to have typically fairly laminar flow, but if I've got a valve inside there, in a normal valve it doesn't restrict it much, but it still is more restrictive than the open chamber is. So inherently a valve should be more stenotic, so to speak, or a higher flow velocity through the valve tips than through the rest of the chambers. Okay, so CW goes through there because theoretically if there's nothing else going on, we've got the highest velocity should be there, and we want to catch that with continuous wave Doppler. Good.
Is there any way you could just show us real quick, like, where we're sort of standing
Yes.
on there for, like, each
That's why I got the heart. Okay, so the heart, vessels and stuff up here kind of sits, diaphragm, it actually kind of angles like this a little bit. The top of the heart that you're going to see anteriorly is right ventricle, okay, and then you're going to see a little bit of left ventricle stuff. This is pulmonary artery. The valves, from the valve's perspective, the pulmonary artery sits closest to the chest wall. It's the most anterior structure. The most posterior valve is the mitral valve. Okay, and then tricuspid and aorta are in between. So aorta and then tricuspid and then the mitral valve. So if we're looking at pulmonary artery here, here's our indicator. We want to see the aorta comes out behind that. It should have this type of a twist. You'll get into pediatrics next fall with Mark, where we'll talk about what happens when it doesn't twist correctly and we have these other anomalies going on. But for the adult heart in a normal situation, we're basically lined up over the aortic valve here. So I take this off. This is pulmonary valve. Okay, aortic valve. Thank you. Aortic valve is behind it going through here, but when we're interfacing it, you're basically lining up with the ventricle and the aorta. So we're kind of in between the pulmonary and the tricuspid. So that's where we start off with our peristernal long axis. Then we sweep to the tricuspid valve down. So if I want to see that valve, I go off of the aortic valve and point down that way. That's why we tip down that way. And then from here we go this is kind of our reference for all these views here. So if you lose yourself on these, go back to this, line it up so that it's maximum long axis, and then reevaluate where you're at. And we might need to jump up or down a rib space to be able to see those things. But from here, we're tipping the beam up or sweeping the beam up to point to the pulmonary valve now. So that you're going to catch some of the right ventricle here. You're also going to catch some of the left ventricle. Okay, more of the anterior aspect of that left ventricle. So does that help? Mm-hmm. Short axis, we're going to go basically go back to your long axis here, turn 90 degrees to it, that way. So my indicator now points towards my left shoulder. Now I'm on top of the aortic valve, but I've also got the pulmonary valve and the tricuspid valve. So I've got all three of those valves in a plane. I can't quite get to the mitral valve in that same plane, so we're not going to quite see that yet. That's when we move down just slightly. We're going to angulate down or sweep down out of those valves to the mitral valve level, and then we sweep down or slide down to the mid-ventricle and then to the apex. Okay? So when we're here, we're kind of sweeping a little bit on these, but then you might need to slide down and away from the sternum towards where the apex is, and then angulate a little bit until you square that up and get it nice and round for each of these views. Get the fish mouth on this. I need to be hitting that perpendicular to both valves, and then below that, papillary muscles need to be attached to the wall, and then beyond that, we want to get past the papillary muscles. We shouldn't see any real remnants of the papillary muscles if we're truly at the apex, and then we just see that residual little donut hole. Okay?
And you were saying like kind of rock your way down?
Yeah, so in class I was kind of showing, see if there's something I can use. Well, how about a transducer? That would be great. So when I'm scanning, so I'll use the transducer like, I'll be scanning along, and Tammy and I, we all do it a little bit differently, and that's okay. When I'm scanning, say I'm with my left hand, I always have my pinky and the side of my hand resting on the patient somehow. Of course, you know, in the breast area, you want to be careful. But you rest your hand on the patient because you have to stabilize. Otherwise, you death grip the transducer and you're trying to hold it, and then that's what gets you repetitive stress injuries because you're always gripping it too hard. So anchor yourself. So if I'm scanning my leg, for example, I'm going to anchor myself like this. That way I can kind of use my fingers lightly with a light grip and manipulate the transducer. But that way I'm not falling off and sliding off into other areas. If you do the death grip and you're not anchoring onto the patient, your hand tends to drift off as well, and that actually gets you in more trouble because you end up in areas that you shouldn't be. Just saying. So kind of anchor the hand on it. If I'm in apical views, I actually anchor the side of my hand that way. So I'd be resting up like this and then just kind of lightly manipulating the transducer. I'm not death gripping it. Keep a light grip on the transducer, but anchor your hand on the patient.
Oh, so you use the back side of your hand when you do that?
If I've got an underhand grip, if I got an overhand grip, I'm using this side.
So you should pretty much hold as close to the transducer
Yes.
as possible.
Yes, the worst thing you can do scanning is doing this, try and be like, I don't want to touch the patient. How is it in vascular? I mean, sometimes you gotta, in vascular, sometimes you can't get your hand up close because you're actually literally underneath the folds of the patient and you're trying to hold that transducer, right? So you do the best you can, but you want to anchor yourself as best you can. If you're trying to do it like this from the distance at the end of the cord, you're not going to do as well, and you're going to be sliding all over the place, and you're going to be death gripping because that's the only way to hold it stable. If you can stay close to the patient, you can have a relaxed grip and move the transducer. And then Tammy and I were both talking yesterday, in some labs, people might get mad at you for doing this, but when I'm scanning, so say I'm doing scan, I personally actually hold underhand for parasternals because for me, it's more comfortable. When I hold like this, it binds up all my muscles and it gets tense. So for me, it doesn't work. So this is a better method. I actually hold it loose, but my hand is against the patient, and I find my window, but then instead of trying to do these weird manipulations like this with my hand kind of torqued, I just take and just do this. I take my hand and twist the transducer because I know from here to here, this is a 90-degree turn, so I simply take that and I just go 90 degrees. I might still have to tweak it a little bit and twist it, but this hand, it quickly gets me to where I need to be. Instead of trying to inch my way through and wasting a ton of time while I'm trying to tense up all my muscles trying to hold that transducer. So for me, that's a very quick motion. Tammy said she does the exact same thing. Other sites may be like, don't ever use your other hand. Whatever, if it doesn't hurt you, that's good. And then what you're saying is when I'm trying to manipulate my window, so I've got my parasternal long axis here, so I might be going along, but I'm hitting ribs or I'm hitting lungs and I need to move. So maybe I'm too close to the sternum, which is obviously going to create artifact, or I might be too close to ribs, which creates artifact. Maybe I've got this perfect, beautiful, these are my ribs, my fingers are the ribs. I've got this beautiful view right between there. The transducer doesn't sit between the ribs. It doesn't fit right between them, so it's kind of on top of them. And the beam is going between them. So as I manipulate that transducer, I got this perfect view. Now I tip down to the tricuspid valve, and the transducer is hitting right on the rib, and it shadows out. So I need to move the transducer a little bit and kind of angle through so that the beam gets between the ribs and not letting the edge of the transducer slip into the groove. Because if it slips into the groove, all you're going to hit is bone. So what I do is I kind of walk my transducer, I kind of slide it and inch it. So I move up and then angle, and then up and then angle, or I go down and angle up and down and angle up. That's how I do it. Tammy uses a circular motion, so she'll be there and she'll just kind of go like this, just doing little circles trying to clear up the window. How do you know when you have a good window? From what you've experienced already, how do you know your window's better?
You can actually see what you want.
Yeah. So I call it pops out. So you're scanning, and then all of a sudden, without me changing any gains or anything like that, the view just, boom, there it is. You know when you have a good window. So if you're struggling along and it's kind of dark and hazy, try something different. It's obviously not a good enough window. If your eye's telling you and you're kind of fighting what's going on, it's not a good window. Find something different. So how do we get a better window? Okay, either rib spaces or even those very slight motions might be just enough to get the beam between it, and you might be okay in that rib space, but you got to kind of move mildly in there. If that doesn't work, jump a rib space, okay, and then try again. And then what else can we use on the patient to help that window? Breathing, okay. I cannot emphasize enough in echo in particular how important breathing is, and I tell students this every year. And every year students get through, they don't do the breathing stuff, and then you come in the room, Tammy or I, it's like, okay, hold the breath, boom, the most beautiful view you've ever seen. Okay, breathing is absolutely critical in what we do.
Is there like any specific way to like have the patient breathe? Like, I don't remember ever learning about that.
It is very specific to the moment. So unfortunately, no. Generally speaking, in parasternal views, because you've got all this lung and stuff up coming kind of around the heart a little bit, if we get too far away from the ribs, so we're fighting the ribs and the sternum, but if we get too far away from there, we're getting onto lung. Any lung comes in, a deep breath is just going to push that out. Patients do what's called a quiet respiration, where it's sort of in between. It's not totally deflated the lungs, but not totally inflated the lungs either. And that's kind of where we do most of our stuff. Without having to make the patient do stuff, that's kind of where you're scanning it. But up in these views, you might get parasternal long axis fine. Usually tricuspid valve's pretty easy to see because now we're off of the lungs and right on top of the ventricle. Pulmonary, has anybody ever had difficulty with pulmonary? All the time, okay? It's closest to the chest wall, but it's also close to the lungs. So it's a very difficult spot to get. So actually sometimes for the pulmonary, instead of going up a rib space to be over top of it, you actually want to come down and angle up so that you're using the right ventricle as a window into the pulmonary. So sometimes you kind of have to go the opposite direction and sweep the beam back up to what you're looking for. And then in addition to that, because it's close to lung, if I have the patient breathe out, that tends to help. So generally speaking on parasternal, breathing out tends to help. And generally speaking on apical views, breathing in tends to help. But is it just a breath in or just a breath out?
Holding it?
No. They do have to hold it. So instructing your patient is really important. So you'll notice that I tend to tell them to breathe in and then breathe out. The reason for that is as I scan, and this is just from my experience, as I'm scanning, so everybody right now just breathe out and hold it. Breathe when you have to. Okay, is it hard or easy just to, on the command, just breathe out and hold your breath? Is that easy to do? Okay, now take a breath and go, and then blow it out and then hold it. Is that more comfortable? Yes. Why is that? Because we're refreshing the oxygen in the body first, so the patient psychologically and physiologically doesn't have to hold their breath. It's not as hard to hold your breath, because before you didn't have any warning. It's like throwing you into the water all of a sudden and you start freaking out. Whereas if you have a chance to gulp some air in, or not gulp it in, but to breathe it in and hold it, now I can go down longer and I'm prepared for it. So from my personal experience, I find that if patients do a breath in, not a big breath in, but just take a small breath in and then breathe it out and then hold it. And you have to tell them, hold your breath, don't breathe. Because what will happen is they'll hold their breath and they start breathing again right away. You didn't get your window. So the commands that you give the patient are very important to them complying with what you need and getting your echo into the position it needs to be. This is where your time factor is going to increase significantly, is if you can control the breathing and you know how to do it accurately. For me, that came when my 2D echo got much better when I started doing stress echo, because I had to get them to do it really quick. And you learn how to command the patient, not in a mean way, but firmly enough to tell them what's going on. The other thing that we have to do, especially with apical views, is you have to anticipate where their heart's going to be, because the other thing is, when I tell a patient to hold their breath, are they going to hold it exactly where I told them? Okay? It's like the EKG. So we get the electrical signal that tells the heart to squeeze. Does it squeeze immediately on the R wave? No, there's a time delay. So when I tell my patient to stop breathing, it takes about 2 seconds for them to actually hold their breath. What happened in that time between those 2 seconds? They've been breathing and the heart's been moving. So you have to anticipate. So often when I'm scanning, I know that I need to get a 4-chamber. I'm sitting on a good view. I see it coming in and out with respiration. And I tell them when it's about here, hold your breath. And by the time they actually do, it's right in my view. Okay? If I tell them when I see a good image, guess what? It's past what you thought it was going to be. So you have to anticipate and tell them before it gets to where it's going to be. And you can only do that by watching it and seeing it come in and out, and then you try to time it when they're going to actually hold it. That's how you do it. And you got to move quick. You got to get your images quick, because the other thing they do, they'll hold their breath. They breathe in. So everybody breathe in. Hold your breath. Okay, hold it there exactly for as long as you can. What do you notice you're doing? Okay, you breathe. So you breathe in. I hold my breath, and then I'm still holding my breath, but they relax their chest. That moved everything. So you've got a very short time frame. Your first couple of seconds are the prime time to get the stuff you need. But when you get good at doing echo, you can go to this, you can get your view here, you take a clip of the view, and then I can take a clip of this, and then I can take a clip of this, and I can get 3 or 4 clips in on the same breath hold if you're good at it and know where your keys are and don't have to search for them. That's the stuff that makes your time go fast. Okay? You can scan a normal echo. They'll never recommend doing this, but you can scan a normal echo with measurements and everything in 15 minutes. Okay? Right now, you can take 15 minutes. No, we got a whole heck of a lot to learn.
I could get one view in 15.
Exactly. So, yes, it seems like a ton, it seems like a lot, and right now it seems completely daunting and overwhelming. The reality is, once you get good at this, and by doing the same protocol every day, by this summer, we'll be to the point where we can scan a case in an hour. 100 images and clips.
Well, because even a second year I was talking to, and she's doing it in Coeur d'Alene. She said she can get hers done in a half hour easy.
Yes.
Like, or 20 minutes or something like that.
And she's a student still.
Yeah.
So it is completely doable. It's going to seem overwhelming, but we do get there, and you will get there. That's a normal echo. Now you get a difficult echo, and you're going to still spend a good hour sometimes, depending how tough it is, because they can get tough.
I mean, are they obviously understanding about that? Like if you write it in your notes, like this was a difficult patient,
Yeah.
if you're running over.
Yeah, so in my quality control job, what I do is I'm not with the patient, I'm not with the sonographers they're scanning, I'm looking at images just like a radiologist or cardiologist is, And I have to look at a lot of things in the image to notice that, because the text don't always put down, you know, what was difficult and stuff like that and all the intricacies. We have to be able to look at it and understand that that was a tough patient. I can tell by what they did on the parameters of the physics of the system. All those numbers that are written on the side of your system, they tell me what you've been trying to do. They tell me what your maps are. They tell me what your dynamic range is. They tell me if you have harmonics on. They tell me if you got compounding on. I can tell all that information based on what's on the picture. And I can tell that a sonographer really didn't try when they've done their study in 6 minutes and they haven't changed a single parameter. Okay, then I'm like, bull crap, you didn't do nothing. Whereas the tech that went through, it's like, I tried this, I tried this, I tried this. They give me totally crappy images, but I can tell they tried stuff. Okay, that's totally different in how I'm going to handle that situation. If you didn't try, I can tell you didn't try. Okay, it says in the textbook that looking at a gallbladder alone, so it's just one little fluid-filled structure, it should take 6 minutes to have properly evaluated a gallbladder. That's one little structure. I've seen people do entire cases of an abdomen in 6 minutes and just give me garbage images, and then they're like, oh, it was just a tough patient. No, it wasn't just a tough patient, you didn't try. Okay? You can tell those things just by the image. I digress. Let's go back to labeling. So that's our 3 long axis views. So know the anatomy of those views, know what valve you're looking at, what chambers are associated with it, know the inflows and outflows relatively. Okay, those are important. Since we're talking about inflows and outflows, if I'm talking about mitral valve and LV, show me where the inflow and outflow of that is.
Where?
So where's the inflow of the left ventricle?
Inflow?
Inflow's coming in from
The atrium.
the mitral valve area. So the mitral valve, so that posterior aspect of the LV is where your inflow is. The outflow is the LVOT. It's going out just before the aortic valve. So it's just where it comes in or just where it goes out. In the slides that we went over online, you'll see that we talk about trabeculations and pectinate muscle and stuff like that. Those are kind of muscly ridges. In the ventricles down near the apex, there's going to be a lot of trabeculations, and that posterior aspect of the heart, there's a lot of trabeculations. As we get into the outflows here and up here, that muscle becomes smoother. It becomes compacted and smooth because you want to have a nice smooth transition of the fluid going out. So just anatomically, that's what you'd see. In the atria, right atria we talked about in particular, the back side of it is smooth and the anterior aspect is pectinate muscle, which is similar to the idea of trabeculated muscle that's in the ventricle. Good. So, how do we get to peristernal short axis then? Okay. So we turn 90 degrees clockwise so that the indicator now points to the left shoulder. Ish. Why do I say ish? Because one person's heart may be going 45 degrees, another person's heart may be going vertical, and another one may be coming kind of up this way. So it depends on where the heart is. So line it up on the longest axis, and then it's 90 degrees to that dimension. Just a point to, if I've got a transducer is up here and it's kind of pointing down, and I'm looking at a structure and I want to see it in 90 degrees to it, I need to have that straight down the center, because when I turn this 90 degrees, this is my beam turning 90 degrees. So whatever this line goes through is what's going to be turning in my image when I spin it. Everything else is going to be moving, and what's in the center is going to be staying, hopefully. So whatever you want to line up, whether it be a 4-chamber view, and I want to go to a 2-chamber, when I turn this, I want it straight down the middle. If I've got my line coming through at an angle like this, am I going to get a good 2-chamber when I turn it? No. I mean, I might have a beautiful 4-chamber that's laid out this way, but when I spin it, I'm going to get, well, this is what I'm going to get. I'm going to get that. So this is going to turn, and basically I'm going to get some big ovoid thing. Okay? It's not an open ventricle because I'm closing off the valves and I'm missing the apex. Okay? So it needs to be exactly in the center of it when you turn it, because when you spin it, you're going to be looking to try to line up to these views. So if you can line this up perfectly here, when I spin it, I should have almost a perfect 2D view, or a 2-chamber view here, and then I spin it again, I should have almost a perfect long axis view. But I need to be exactly over the apex, and I need to be swept so that I'm exactly in the middle of the chamber. If I'm not, that's where you're going to struggle, okay, which kills time. Okay, so parasternal long axis anatomy, what are we looking at? So this is the base level, base being the valves. Aortic valve, yes. You guys can help out if you want.
It's the right ventricle.
That one?
Or
Okay, here's a clue.
that one.
That should be the left one.
Thickness of walls. Let's start at the top. So, transducer's right on the top. Okay, now we're 90 degrees, so we're 90 degrees to the valves here, the top 3 valves. So, what's the first things we hit?
Oh, that's a
Right
right atrium.
It's actually,
It is a ventricle.
it's the ventricle. So, couple clues. Thickness of the wall. Other clues, look at the valves. Which way are the valves pointing?
Into it.
So they go into the chamber that they're going to be supplying to prevent the backflow from going the other way. So look at the valve. So we know that this is right ventricle because of the thickness of the wall. Let's label the valve. So the one on the left is, that is tricuspid valve. Okay, and this is how it should be oriented on the left side of your screen by ASE standards. And then pulmonary valve is the other side. So you can tell by the valves, these two views here, if I didn't have the left ventricle in here, these two look pretty similar in our views because we have a whole bunch of messy stuff going on down at the bottom. So you may not see that perfectly nice rounded atria. You might just kind of see some artifact and stuff and see a valve and you're just happy to see the valve. So what direction is the valve pointing? If it's pointing up into the ventricle, that's my tricuspid valve. If it's pointing out away from the ventricle, that's the pulmonary valve. So you can tell by these the direction that the valve tips are pointing. Okay? And then in this one, what is this here? So that's the main pulmonary artery, and then it bifurcates. And which side is what?
Right.
Okay, we've done this one before, so we've got the right going towards the right side of the heart, and then which actually wraps around the underside of the heart, and the left goes out right away to the left lung.
Does it matter if we know if are these the lower ones or the upper ones?
So those are pulmonary veins. These are pulmonary arteries. Okay.
There's 4 of those.
Oxygenation, just for kicks and giggles.
Nope.
Low.
Is it highly oxygenated or low oxygenated?
In the
So it's an artery. It's a pulmonary artery.
It's low.
Okay, so this is right heart, so it's going to the lungs. It needs to be supplied with oxygen, so it's low going in. And so always remember that. So for a registry, you want to know oxygenation levels roughly in each of the chambers where they are and the arteries, and you also need to know pressures. Okay, I presume Darren's been covering some of the pressures and stuff in hemo.
Yeah.
We're
Okay.
starting.
You need to know that for registry, so don't forget that stuff. Know your oxygenation levels and know your pressures, relatively speaking. Good, so we've got that. What is this right here?
Septal wall. Or, oh,
Yes.
Oh, it's the atrial septal wall.
It's atrial septal wall in particular, and that's the left atria. So know what septum it is you're looking at. Okay, what happens to sit in that interatrial septum that could be significant?
Like a defect? Is that your
Could be a defect.
What is
the foramen ovale?
So foramen ovale is the normal. If I'm looking at it, it's going to look like an ovoid shape, and that's made by your septum secundum and septum primum. They come together, they fold a kind of a valve over top of that. In fetal circulation, that's open, allowing blood flow to go across to bypass the right heart because it doesn't need the lungs when it's in the womb because it's oxygenated by the placenta. So if I see problems with that wall, I'm looking for holes and stuff going across it. I'm looking for leaks going across it. And we'll talk more about those later, but that's important to know the anatomy, because that's when you see stuff that's not right, we need to point it out.
Because do you usually like, do you put color over that? Like,
Yes.
And I know sometimes it bleeds over. I mean, is it real obvious if there's like?
It's not super obvious, but to put it in perspective, 25% of the population is walking around with a PFO, a patent foraminal and don't know it. Okay? I can't tell you how many we've caught in our lab just doing scans. Okay?
And is it like super harmful? I mean,
No, it depends. I mean, chances are if we catch it like in our screening, while we're doing screenings, patients typically don't come in with symptoms of anything. We just happen to see it. The risk of that is if that person ever gets like blood clots in their legs and stuff and it kind of breaks off, you guys know what the pulmonary embolism is. So it breaks off and can cause issues with the lungs. Well, if I have an open patent foraminal valley and I get a chunk of that clot goes across, now where's it going? Potentially to the brain, okay? So that's a problem. So we want to be able to point this out, and it's actually very common in echo to look for that. So if I see a septal wall, an atrial septal wall that kind of looks like it's excessively moving or it's kind of bowed out or aneurysmal, chances are that's reopened that hole that closed out after birth. In a young healthy individual, that should be closed. And then we've also got septal defects where it actually didn't ever close and it had a residual hole from the get-go. So there's two different types there. One's kind of a normal process that you acquire because of our great diets and stuff in America, and we get bigger, and things that cause problems stretch out our chambers. When you stretch a valve, what happens? It reopens it. Okay?
so can they like go in there and like put a patch kit on that?
Yes. Yeah.
More or less.
So it's called an Ann Platzer device. They go through and they poke through that, and then there's like two umbrellas type things, and then it will close over top of it and seal that up. Makes it harder for echo because now I got this hard, rigid structure that's in the heart that's giving me more shadows to deal with. Okay, but that's the reality of what we do. So that's the septal wall. So good anatomy. Next view. Fish mouth view, yep. So where he's labeling, so there's LV, that's correct. So where he labeled the mitral valve, that is correct. Where's the orifice of the mitral valve if I'm looking at it from that perspective? Right where the label is.
Yeah.
So the opening of the valve is in here. So label the leaflets. So anterior, posterior, do you agree?
Yeah.
You sure? Yeah, just checking.
Yeah.
So transducer's anterior.
Yeah.
First one we hit is anterior mitral valve leaflet. Second one is posterior leaflet. So this is actually a bigger valve. It's longer, but the posterior valve actually wraps more around. So the posterior valve is actually longer around this way, but it's shorter. But a lot of the issues come with the anterior mitral valve leaflet. Okay? Just FYI. So we're just looking at the very tips of it to see that. If I'm going through the heart just in a 3D perspective, we'll say our apex is out here, the atria are on that side of the board. If I'm looking to go out the aorta, where do you think the flow is going to go from that perspective? This is sort of an indirect assessment of where it is. Okay? But where on this image would the LVOT be, for example?
It's atria on the other side of the board.
Yeah, other side of the board, apex is out here.
So where would
So where would the LVOT be more directed towards? So if I'm showing the flow and I'm squeezing the heart now, this is where my mitral valve is. The flow's stopping right there because we don't want it going out that way. Which way is the aorta relative to this?
that way? Ish.
So draw in here where the flow would go pass through.
Well, it's come out towards
So it
us.
comes into the ventricle this way, and when it goes out, it goes
That way.
Like
up in here. So this is my LVOT area as I'm squeezing out that area. Just remember that my big vessels, the aorta comes off anteriorly to the mitral valve, so if I'm sweeping through it, I expect the LVOT to be in this area. Do I expect it to be over here? No, because it needs to go out in that area, because when we're scanning that, we see some right ventricle on top of it. And actually, I left a VSD on there, sorry. So we'll put our membranous portion of the inner ventricular septum there. Good. So that's our view. Mid LV. So this is base level. Base level of the muscle, the mitral valve level. Don't confuse that with the base level of the valves. Okay? The valves are formed with a skeleton. It's a fibrous skeleton. It's insulated, so it doesn't allow electrical conduction across it, except for through the bundle of His and AV junction. So this level here, what are we looking at? We got papillary muscles. Now we need to specify the specific papillary muscles now, because in the left side of the heart they are pretty distinct, whereas the right side we have three fairly indistinct papillary muscles.
So like right and left, or?
So this is posteromedial. This is anterolateral. I think in Dennis's stuff in those slides they actually called it posterolateral, which is what they used to call it. New terminology. So posteromedial is always by the septum.
Posteromedial?
Posteromedial. Good. And then chamber is LV, good. And RV, good. Where's the septum? Interventricular septum on that. It should seem obvious, but it's in there, okay? So right now I'm just going to be pointing out the septum because those are landmarks that help us distinguish what we're looking at. If I took this view and totally twisted it, this is called the anterolateral, and yet I drew them kind of equally at the bottom of the image. Why is that? This is posteromedial. This is actually on the infraseptal wall. This is the anterolateral wall. So if I actually, anatomically speaking, this one is actually higher than this one is towards the chest wall. But it's how we interface it. Are we exactly in the center of the chest or on the center of the heart? No, we're actually a little bit over to the left, and the way we're angling it, that's just how we tend to see it. But if I drew this image and twisted it around, how can you tell that what's what? So say I drew it like this instead. So we'll go there, we'll draw a papillary muscle there, one back here. Okay, and so same view, I've twisted it. This would be more like what a subcostal view looks like. But how can I tell that this is posteromedial and that's anterolateral? Because this is very posterior. Look at the septum, okay? Because posteromedial is by the septum. Okay, so look at your landmarks to coordinate that.
When you're talking about the sections like on the mitral valve level, how the top was anterior but the bottom was inferior?
Yes.
Like with the why is it not posterior and anterior? Why is it anterior?
It used to be.
Inferior?
So the terminology has changed because of the 17 wall segment method we use now. It seems to not make sense, but it actually does. There's some logic behind it. When we go over wall segments, you'll notice that everything is either an anterior something or an inferior something. Where we used to have an inferior wall and we used to have a posterior wall. So you'll still hear me call this the posterior wall, because that's what it was, and the 16 wall segment method, which is an older method. Now they've gone to 17 wall segments, but the terminology actually does make some pretty good sense. So pretty much you have an anterior, so you'd have a straight up anterior wall, which is what you see on two chamber, and an inferior wall, which is what you see on two chamber. If I'm in short axis, this is the anterior, this is the inferior. This used to be posterior over here. Instead, this is now posterolateral, inferolateral. This is anterolateral, anterior septum, inferior septum.
Okay.
So it's either an inferior or an anterior, and then it's either a septal or a lateral or just anterior or just inferior.
I mean, but would
So it's actually a little bit easier to learn than it used to be.
okay.
I know it doesn't make sense, and there's
It
still...
could be, I mean, technically posterior lateral, like, I mean, that'd be the
Right,
technically the same.
that's what it used to be, is posterolateral. So,
Okay.
new terminology. I do think the new terminology, it's sort of like looking at your standard system down here versus metric. Being Canadian, of course, I'm metric, but metric is actually easier to learn, and they did that because of the way that it is to learn. Whereas some of these other things, like knowing that there's 5280 feet in a mile, I think is stupid. It's just me. Canada used to have that same system, and then they switched to metric. I personally think that metric is a better system to learn, which is why it's always used in science and math. But I digress.
But hey, why?
But that's why the
We like to make things
label.
difficult in America.
Right. Yeah, you know, we do what we do. Keeps us employed. So, good. And then the last one is LV. Okay, so I kind of drew this little thickening of tissue around here. Why would I draw that?
Right ventricle.
That's where the septum is, but when you're truly at an LV apex, you really don't have much of any. There's no chamber left on the RV. Because if you look on this, I almost always draw on an adult heart, I always draw the LV higher than the RV apex. Because it is. Except when there's something wrong, then it becomes equal or even bigger than the left side. And that's problematic. So if I am seeing that at that level, that's problematic. Okay? So that's what it should look like roughly. Good. Did you want to break? Someone else
Somebody else wants to come up.
come up?
I think you're doing a great job.
Brooke volunteers, all right.
All right, keep going. It's no big deal. We're almost done this. All right, 4-chamber view. What chambers have we got?
Left ventricle.
So LV, RV, that is correct. Always make sure they're oriented correctly. Once you get these down somewhat, and then you get onto a system like the Toshiba where it's kind of, you got to intentionally go backwards to make it right, it seems. You're fighting yourself because you know you need to go a certain way, but it doesn't look right, and you're like, I'm trying to go that way, but it's going this way. It's like, yeah. Sometimes you just got to look at your anatomy again and be like, oh, I'm backwards. So often we see that with when people go to the 4-chamber right away, you can see it's backwards because the RV and stuff is smaller than the LV, but it's on the wrong side of my image, which is the correct side for Mayo Clinic method, by the way. Or I'm on peristernal view and you're fighting that view. It's like, why can't I get these valves and stuff in? Why can't I get the aorta open? Well, because your ventricle's over here and your aorta's over here. It means you're twisted around, your transducer's backwards, or it got flipped on the screen for some reason. It's doing good. RVLV, tricuspid valve, mitral valve, LARA, right pulmonary valve, left pulmonary vein, and left pulmonary vein, descending thoracic aorta. That's great. I'm not going to care as much about tricuspid valve, but the one leaflet that's attached to the septum, guess which one that is?
Septal.
Septal, good. Mitral valve, which one's anterior and which one's posterior?
Supposed to be on the free wall?
Hold on.
Yes. And the one on the septal wall is
Anterior?
the anterior. So when I'm looking at a mitral valve from 4-chamber, you'd think that the opening would be right in the center, but I already mentioned that the posterior leaflets are very short. So if I'm actually looking at the valve in this view, it would actually be kind of like this with a short posterior leaflet. So where it comes in, the inflow is actually towards the lateral wall. Okay, when I'm looking at that from a 4-chamber perspective. It's not going to be right in the center as you sort of think it would be. Okay, great. View under that is apical 5-chamber, or it could be called apical 4-chamber with aorta. Which is perfect. What is my primary focus on this view? What's the whole point of this view?
Getting the aorta.
Top.
So it's not getting the 5 chambers per se, it's getting the aorta leaflet tips open. If I can't see them opening, I can't tell if it's getting through the valve properly, and I can't tell if it's stenotic or anything like that. So I need to be in the center of the valve. So I really honestly don't care that much about how nice my ventricle's set up or the atria. You generally want to be in this perspective so you can see these 4 chambers, but what's most important is the valve itself. Okay, because this is also where we primarily do our Doppler, and if I don't have a good 0-degree angle, it's not good enough. Okay? Good, so let's label the chambers and vessels. Good enough. And then aorta going out. So focus on getting that, and the issue that people have the most with getting this properly when they're scanning is, so first of all, from apical perspective with our transducer, when I come to 4-chamber, the indicator is going to be towards the floor but tilted up just a little bit this way. So we're sweeping through there. 4 chambers here. We tilt anteriorly to see the aorta, which is behind this wall right here. So there's aorta. It's up inside here. 4-chamber is angled back posteriorly towards the spine. To tip it up from the apex to see the aorta, I have to tip it up this way anteriorly. I often have to come a little bit more lateral to be able to see this well and to line it up so that it's straight up and down. If it's not straight up and down, as you'll see in the Doppler sections, you can get some very inaccurate information. And then because we're, we're doing squaring and different things like that, that makes the error of margin much bigger, or the margin of error. Good deal. Any questions on the 5-chamber? So that's primarily, that view is primarily to assess the aortic valve. We're going to be doing a pulsed wave Doppler in the LVOT, which is on which side of the valve?
The LVOT?
Yep. So the LV outflow tract is just before it leaves the valve. So it's all relative to the ventricle. So it's on the out. So this is the inflow side of the ventricle. This is the outflow side, but it's before the valve. Okay. So when we Doppler these, we always do a comparison of the before to the after. Okay. So we pulse wave that because it's range specific, and then we do a Doppler through the valve with continuous wave Doppler.
So you said for apical, it's indicator towards the floor, but then you said it's tipped up a little bit.
Yeah, so it's kind of, so if my patient is directly on their side like this, I'm going to be down like this, but slightly tipped up like that.
So
it's slightly rotated.
In line with the tilt of the heart.
Yeah, because your first view is going to be the 4-chamber, and to get the 4-chamber, if I'm angled correctly, I want both of these chambers to be as open as they can each be.
Yeah.
I want them exactly in the center of the LV and exactly in the center of this, as well as the atria. Now, I said already that when you're looking at the heart, the inflow tracts are at the back of the heart. They're near the spine. So I'm actually tipped back anteriorly, or posteriorly, and then I have to tip anteriorly intentionally to get the 5-chamber to open. So these are very posterior structures in the heart. And if I sweep back even more posteriorly, we start to lose the atria, and then what comes across the back here is a nice long, the coronary sinus wraps around the whole back of the heart here, and then, wraps around the left side, and then it dumps into the right side here. But if I'm too far posterior, I see a line of, almost a tubular shape of a blank space there, the fluid-filled space. So if you're seeing like a right atria that looks like it's full, but on the left side I see this weird long thing like this, that means that you're twisted wrong, and you need to come from posterior and twist it up more that way to open the atria. That's a very common thing that people will do, and then of course if you go too far anterior, you're going to hit the aortic valve. And if you're able to, and I go even more anterior, the right ventricular outflow tract, what valve sits in front of the aortic valve anteriorly?
Pulmonary.
Pulmonary. So if you really tip anterior, you're actually going to end up in the pulmonary valve, which is really tough to get because from that perspective, it's all ribs. Okay? But some patients, you can see it. All right, and then 2-chamber. So what shape is the heart, the chamber of the LV?
Kind of conical.
Okay, it's conical, it's a hemi-ellipse is what it can be called, or bullet-shaped. So it's typically fairly rounded. Usually in the apical, it's usually rounded in the center of it. Why did I draw the 2-chamber, do you think, this way? Because that's how it is. So it's not perfectly like that. When I turn on a two-chamber, one of the ways that you can know that you have a good two-chamber, a lot of people will get a two-chamber that looks like this. Okay, centrally located just like that is. Okay, valve in here. Okay, but they're not, if you don't look like this, it actually kind of bows this way. That wall, that's the inferior wall, and that's anatomically what the heart actually looks like. So it actually takes what they call an inferior dip at the tip here if you have a proper two-chamber view. If you don't have a proper two-chamber view and it looks rounded, there's either pathology going on or you're not exactly in the center of it. You're foreshortening the chamber.
So you want kind of that, like, knife?
Yeah, it should kind of bow this way, and then the anterior wall typically goes out like this. Okay? Anterior wall is going to be the harder one that's typically more difficult to see. You're typically going to see this wall pretty well because this is anterior, it's close to the chest wall, it's the hardest to get that perspective from where we're at. Okay, so that's two-chamber. Remember, to get this good, you want to be exactly down the center of the LV. All right, so go ahead and label what we're looking at anatomy-wise. Good left atrial appendage, left atria, mitral valve.
And is this a coronary sinus?
Coronary sinus again, yep. So in this view, if I saw the descending thoracic aorta, it's going to be now in long axis, so you could see that. Okay, so I already mentioned that this is anterior wall and inferior wall. Remember that coronary sinus is an inferior structure, left atrial appendage is an anterior structure. So if you're confused about it and you got your image flipped around and you're seeing your coronary sinus on the right side, you need to flip it around, okay? So maybe you turned the wrong way to get it.
So from the 4-chamber, you sweep up to the 5, then you go back to the 4-chamber?
Yeah, to get to these views, you want to go back to the 4 because that's where you're most central. If I go off the 5, I'm going to lose some of this other information.
And then is it counterclockwise rotation?
So this is counterclockwise, and it's 120 degrees. And then this is another counterclockwise, sorry, CCCP, is that what it is? Just kidding. That's another 120 degrees from this view. So these three are 120 degrees from each other.
Yeah, I thought they said 60 degrees here.
I thought it said 90 actually, but
Since you're using the apical 4-chamber view as a reference, the other apical views are readily derived by rotating the transducer counterclockwise approximately 60 degrees, and the apical 2-chamber view is recorded.
that's probably right actually. Because I'm thinking of,
So it goes
I'm only going
60,
there and there.
So 60 then 1?
Yeah, otherwise I'd be going all the way around. So you're right, it is 60 degrees.
Okay.
It's not 90 degrees though. It is 60 degrees. I was just thinking.
Yeah, okay.
Yeah, it's counterclockwise. Now you could go the other way, but then you're going to hit 3-chamber first and then 2-chamber.
Okay.
And then it should be oriented like this on the screen. So again, anterior wall should be on the right side of the image, inferior wall on the left side of the image. And then we'll turn another 120 degrees and we'll look at the 3-chamber view, or the apical long axis is the other name.
So that'd be 120 degrees from the 4-chamber then?
Yes.
To that one, right?
Yes.
Okay.
Okay, and if you'll notice this view, what other view does that look like? It should look identical to your apical long axis view. Okay, so if I'm in apical 4-chamber view and you're kind of confused as to how you should have it oriented, if I'm in parasternal long axis and I've got my indicator that way, this is the same view as if I took this right off and just moved it to here. So my indicator points the same direction as I would have had on my parasternal long axis. It's just now that you're right at the tip of the apex, make sure to get it right underneath the middle of the transducer, the LV apex, to get that. Good, thanks. So anatomy, get the anatomy down. Okay, I'm going to erase this, but I got some other stuff to do. Any questions about all this?
Yeah,
Can you take a picture
just-
of it before you erase it?
Go for it. This is the new age of taking notes. So what I will encourage you to do though is don't just take a picture of this, go home and redo this on your own, because the fact that you write it down sinks it into your brain a little bit better. The other thing I wanted to introduce now is the idea of doing a portfolio. So I'm always asked about study guides. The best study guide is one that you create for yourself to make sense of what the reading in the book is. So your job is to now go and put it in your way of understanding it. I want you to start creating a study guide for the registry. Okay, and don't leave that just to Echo. Take your ICT stuff, the hemodynamics, all that stuff, and start building yourself information about the valves, about the chambers, the heart, all the stuff, even the drugs, the EKGs. Start building yourself a big study guide so that when you go back to study for registry, you don't have to reread Feigenbaum, per se. Okay, and you can use other resources to tap into that. So reference your stuff so you know where you got the information from. And then at the end of the quarter, I'm going to, well, even when you're done the sections, you can bring them to me and I'll put those in for grades that you completed. It's just, you know, you either did it or you didn't kind of thing. But I want to put it in your own way of understanding. So if you're a picture person, draw lots of pictures, great. If you're a numbers person and you like a bunch of tables and graphs, great. That's fine. I'm totally fine with that in the format. But I do want you to create the portfolio that is going to help you understand what you're looking at. Whether you get pictures from online of what actual images look like, that would also be helpful. And then any information you can. Does anybody here have the Terry Reynolds book, the coil one? So I didn't put it as a required book this year simply because they stopped making it and students have been having a hard time getting it. But that's the Terry Reynolds book, and if somebody's got some, or you can take a look at mine. What I love about this book, this is a great study guide for registry, because once you learn what the stuff is and why it is the way it is, this is like a fact book. Okay, it simply goes through, and it will start out giving like, let me jump to the beginning of a section. It's going to start out with like patient histories. So, well, prosthetic valves, we won't do that. Let's do a different one. Pericardial fusion. So we'll go to pericardial fusion. So that's going to start out with the definition of what it is. So this is kind of how I'd like you to probably consider doing your study guides. And don't just copy it out of here, because then you're not really retaining the information. So you want a definition, you want the etiology. So why is it the way it is, pathologically, physiologically? Give the patient's history. What kind of things would you see in the history? For example, they have coughs, fever, sweats, chills, tachypnea, all that kind of stuff. Physical examination. What happens when I'm listening to, like, well, they're talking about enzymes here. What happens if I'm listening in a stethoscope, that kind of thing. What kind of things can be complications of it? It does actually have a separate section for auscultations. What do I see on electrocardiogram? So EKG. What does a chest X-ray, CT, MRI, or other types of imaging modalities see? Cardiac cath, medical treatment, what do they do for this thing? Surgical treatment if they do that. And then it goes through extensively the echo stuff. So M mode and 2D, what do I need to see in that? What do I need to measure? Pulsed wave, continuous wave Doppler, transesophageal exams, and then differential diagnoses, and then other notes. Okay, so that's kind of how it breaks it down. So go through those things. So you want to have a pretty comprehensive knowledge of what happens from the time the patient walks in, the histories that they have, the kind of symptoms they're going to complain about, to the lab work, to what is it that I need to get on my echo, to what happens after the echo. Okay, that's going to be a comprehensive base of what you want for registry.
Yeah, I mean, is this portfolio or study guide? It can be obviously typed or written, like it doesn't.
Whatever format you want is fine with me. It's what's best for your study habits, because you know we all have different study habits, like we did with Rick at the beginning of last quarter. We just all see things differently. I've had people go through portfolios. I've actually done assignments for students, and I've had some students that are like, this is awesome, and they do it. And other students are like, that was a complete waste of my time. I did it because I had to. I had one student in my very first year, he was one of those auditory guys, I forget what they call it. He remembers everything he hears. He never took a single note in any class. He sat there and listened and listened and listened. He was one of the top students that year.
That'd be nice.
Yeah, yeah, we're all jealous, I know. I would love to be the visual guy that can, you know, you guys have watched Criminal Minds? So Dr. Reed on there, so like he's watching your book, he's like, you know, he goes through a book in like minutes and he remembers everything. It's like, I'd love that. It's not a reality for me. All right, so know the anatomy. So the next step I want to take is, so we got till 9:30 in this, and then we'll take a bit of a break and do physics. I'm going to go over measurements.
Sorry.
Yep.
The portfolio, is it just for this class, or do we need it for?
I would recommend it for,
Said.
you don't need it for vascular unless you want to build your own separate vascular one. If you plan to take like the vascular registry one day, then maybe start doing that. I would recommend it. For echo stuff for sure. So EKG is going to be on the registry. Hemodynamics that Darren teaches is going to be on the registry. You need to know your Wiggers. So what happens when a valve is normal? What does it look like on a Wiggers diagram? They will ask you questions like, you know, they'll show you some Wiggers diagrams potentially and say, you know, what valve disease is going on here, and they'll give you like aortic stenosis, aortic regurgitation, mitral regurgitation, and mitral stenosis. And you need to be able to see the Wiggers diagram and be like, oh, it's this. That's the kind of thing they'll ask you. So do know the Wiggers diagrams. Don't really care if they know what kind of catheter you're using in the cath lab. That's not really that relevant to what we do. But the Wiggers diagram is going to be important. The pressures, the oxygenation, that stuff's going to be important. Drugs. I think drugs are good to know, so I would definitely have a drug section, and if you understand beta blockers and stuff like that, calcium channel blockers, etc., those types of things could be important on registry. Any of that stuff can end up on a registry.
And then a little bit of physics. I mean,
A bit of physics, yep. Even in the SPI from ARDMS, like Bernoulli equation, that's very much an echo thing. So 4V squared is your formula, it's simplified Bernoulli. Guarantee you that'll be on the registry exam. Even if you've taken and passed your physics already, it's going to be some of that on there. Okay, so don't totally forget that stuff. We'll be talking about it, but there's some things that are echo specific that when they made the SPI, they took out all the modality specific things and put them onto the registry exam, the regular registry, and took them off of the physics exam. I got the opportunity to take all 3 physics exams, which back then when we had 3 distinct ones, the stuff that was cardiac specific was on the cardiac physics exam. The vascular stuff that was specific was on the vascular physics exam. So, good. So let's erase this. Let's start out our very first view. Is what? First sternal long axis. Okay, I was talking to Tammy as well, and I think what we're going to do for lab is we will go back to the idea of, instead of having it's not a full protocol, but for this quarter's protocol, I was going to try having you do the same thing week after week, and then the other day I just realized it's just way too much. Agree? Or you want to do it anyway? No. We can do it. But it's easier if we, and my philosophy is we're going to start with the basics and we're going to add stuff every week. So you're going to still do the stuff that you did before, now you're adding a little bit each week, okay?
could we do even like focus on one type of measurement one week?
No, because then we don't have time to get through it. That's how they used to do it, and then when I got here, I found that students didn't have a clue what they were doing.
Okay.
They got okay at dabbling with that for that 1 week, and then they hadn't done it again for 6 months. And they totally forgot how to do it. So my philosophy is I want to get you in the habit of doing it consistently. So that's why I have you build the protocol, and you're going to repeat the stuff you did before. And it should, you know, after a couple of times of doing it, it should be sinking in. And then you're adding some new stuff to it. So that's how we're going to build our protocol this quarter. Next quarter, we are going to give you the full protocol. And you're going to do the same thing every week at that point, which is what I was going to try this quarter, but it's too much. You're learning a ton of stuff. Drinking out of the fire hose. Okay, so parasternal long axis. So remember I said that you always take a 2D cine of whatever you're looking at. Then you're going to take, if you need measurements, you're going to stop and take measurements. And then you're going to take still pictures of those. Some of them are going to be in systole, some of them are going to be in diastole, so the timing of it and scrolling to those parts is important, lined up with your EKG. And then you're going to do color Doppler on it with a clip, and then you're going to do a spectral Doppler with measurements if needed. So it all depends on what we're looking at that moment. So parasternal long axis, that's a horrible heart, hold on. That's a very bad heart. Okay. Don't care about the descending thoracic aorta, but we'll draw it on there anyway. Okay, so there's our LV. So what do we want to look at in this view? So what kind of things can you see on this image that you would think might be of interest to us?
Wall function.
So wall function, yes, absolutely. So we want to see how well does it thicken. A heart that doesn't thicken is not a very effective heart. Okay, so thickening of the wall is important. What else?
Valves.
Valves. I want to know, what do I want to know about a valve?
Open or close?
Is it opening and closing properly? So the opening is important and the closing is important. So there's things that are going to affect that. So we want to look at two valves in this image for that. What else do we want to see?
Size of chambers?
Size of chambers, absolutely. So we're going to have charts that give you actual sizes of chambers of the ranges that should be in. But we also want to compare them relative to each other. So if I've got this LV sitting here and I've got this massive LA, that's an important thing to note. Okay? So you're going to notice a relative size of things and you're going to catch that with your eye right away. And sometimes it's going to look super big or super small and you're like, oh. And then you put your calipers on and you're like, oh, it's not that bad, because you realize that, oh, I'm totally zoomed up on it. Or something like that, or I'm totally zoomed out and I can't, it looks small but it's actually big. So you've got to pay attention to your numbers, you've got to pay attention to the visual perception of how it looks. And then with the wall thickening, I also want to know not just that it's thickening, but is it symmetrically thickening the way it should? Is it getting that normal squeeze, or is it like thickening here and then here? Is the timing off? Okay, those things are all important to see. So parasternal long axis, we take the 2D clip, and then the next thing we do is we're going to measure stuff. So we're going to start, we could start from one of three things. We want to know stuff about the aortic valve and the size of these chambers. We want to know stuff about the size of the LV and the thickness of the walls, particularly in diastole. We do sometimes measure, and I'll have you measure for now, walls in systole, but most labs don't measure the walls in systole. Why do you think we don't use systole as regularly as we do diastole?
Because diastole is at rest.
So diastole is at rest, yes.
Someone's heart might squeeze harder.
Okay, somebody's heart might be squeezing more than another, so those numbers are more variable. So the diastole is most consistent because that's when it is at rest, that's when the walls are the thinnest, okay? Most consistently. So we're going to measure first in diastole, but then we'll do it also in systole to compare it. So that's the first thing we're going to do, is actually measure walls. So we scroll to diastole, and if I've got my EKG, where is diastole? So diastole technically is T wave, or after the T wave to the next QRS, right? Because it doesn't start squeezing till after the QRS. Okay? So that technically is diastole. Where, you know, we have to measure, is early diastole the same as end diastole? No, or I wouldn't have asked you that question, right? So think about the physiology of it. So mitral valve is opening, it's receiving blood from the left atria, so it comes through the left atria into the LV. We're looking to fill the LV chamber before we squeeze all that blood out to the body. We want the maximum fill that we can get. So early on, what happens, we got this big buildup of fluid behind the mitral valve in the atria, and the heart just finished squeezing, so it's pretty much close to empty. Now it relaxes, the aortic valve shuts, and this big volume of blood just goes rushing out. Okay? Pressure drives everything in the heart. So remember that, maybe even write it down. So pressure drives the valves, pressure drives everything. So that pressure back up creates the gradient across there. The pressure gradient equals out now as it's open for a little bit. So early on I get a big rush of fluid coming in, then it kind of goes down, and then what happens on my EKG? So there's diastole, the valve opens here, it's going along. I get to this point here, that's what? So this is atrial contraction with the P wave, or just after that. Then I get an atrial kick, which gives us a little bit of extra blood pumping out because it's been filling more. And now that little kick of the atria squirts out the last remainder that it can. And then it goes back down to baseline. Okay, so I've got an early ejection that gets a lot of blood. We got diastasis in the middle here that gives sort of the residual gradient that's just kind of residually passing through. And the backed up pressure from the lungs is continuing to push through. And then atrial contraction gives the last little bit, and then the ventricle squeezes and it shuts. Okay, that's our diastole. Okay, so with this, so I asked where it is. So early diastole here gets some fluid in there, yes. Okay, but is it all the fluid? It doesn't happen until after the A wave kicks. Okay, then when we get that rush of the A wave, at the very end of diastole, which happens to be right on the QRS, because the QRS will fire, but the mechanical contraction is a delay from that until just a couple of frames after that QRS. So end diastole is really right on the QRS. End of systole is actually right at the end, just before the opening of the mitral valve. Okay, all of our measurements are going to be done with all of the valves closed. Okay?
Is this in just this view or all views?
All views.
So,
yeah, when I'm looking at chamber sizes and stuff like that, and end of systole, end of diastole, all valves are closed when we're doing these measurements. So if you're noticing on your image that my valve is open, you're at the wrong time. Okay? Having said that, we don't measure the same things at the same time either. So I don't measure the aortic root at the same time as I measure the left atria. So the first ones we're going to measure is the walls. Now the other thing we need to note before we do that is the leading edge to leading edge concept. Okay? So ultrasound beam is coming down. It first hits my interface here. Okay? And then it hits the next interface here. Okay? And why do we do leading edge to leading edge?
most defined.
So what is the leading edge is right here. Okay, that's the first line that hits on that, and then we go to the next line of that structure. So this might be a wall, or it could be a chamber. Okay, it could be all gray in between here, or it could be a black space because we got fluid. But the point is we go leading edge to leading edge because as I drew behind these things here, we've got those artifactual reverberations happening beyond it, and I don't truly know where the inside of that is. Okay? So that's the philosophy of why they did leading edge to leading edge starting way back in the M-mode days. M-mode was the first modality that they actually used before we got the 2D images. So everything is really based off how we used to do things with M-mode.
So then, if we're scanning through that, would the leading edge be technically then the, what we could just call like the top layer, first
Yep.
layer?
Yep. So what we're going to measure, we're technically going to be doing leading edge to leading edge on almost everything. The other ones that we could be doing is an inner to inner, which means that the inside of it to the inside of it, or outer to outer for the example for aneurysms. We measure from the outer here to the best we can see of the outer there. Okay, so those are different modalities, but in echo we're going to do mostly leading edge to leading edge on our views. Okay. So in diastole, right on the QRS, we're going to measure, you can measure the RV if you want. We should be at a perpendicular plane to the direction of the ventricle. Okay, so we need to be 90 degrees to that. We should not be at an angle because then it's not accurate. And then you're going to measure the leading edge to the leading edge on this wall. So that's septal wall, that's IVS. And I'm going to write a small d, that signifies diastole.
I'm sorry, so 90 degrees to
So the direction of the LV is this way.
Okay.
Should be 90 degrees to that, near the base. So this technically needs to be between the tips of the papillary muscles, which is going to be here. There's my cords going across. So it needs to be between the papillary muscles and between the tip of the mitral valve. It should not be beyond the tip of the mitral valve because you can still see some muscle, but that's tapering at that point, so it's not accurate. I need to be probably a good centimeter into the ventricle. But I can't go too far down this way or I'll start calling the wrong section of it. So really, it needs to be the base section of the muscle between the tips of the mitral valve and the tips of the papillary muscles. Okay, so you measure that wall, and then you're going to measure the chamber, so that's IVSD. And then I'm going to measure the chamber size, because I want to know how big the LV is. This is called the LVID, for left ventricular internal diameter.
Sorry, what was the first one again?
IVS,
Yeah,
interventricular septum.
okay.
Inter, not intra.
And that's outer to outer.
These are all going to be technically leading edge to leading edge.
Okay.
So if I'm measuring the wall, it's the very leading edge of that last line that I see.
For the interventricular septum,
Yes,
it's leading edge to leading edge?
Yeah.
Okay.
technically. But it's really right on it. It's going to be more important when we get to the aorta and the LA, the leading edge to leading edge concept. But technically this is what we're doing.
What's LVID again?
So LVID is left ventricular internal diameter, and small d is diastole. Okay, then we measure the posterior wall. So this is LVPW, left ventricular posterior wall, small d diastole.
Okay, so we're doing the outside wall just to the inside of the ventricle? I guess so.
So yeah, so here you're measuring right there, just on that leading edge to the leading edge of this wall, just before the really thick pericardial line that you're going to see back here.
Okay, that's what I was confused, because you said leading edge to leading edge, so I wasn't sure if it was like say on the interventricular, if it was the far leading edge
Yes.
to the internal leading edge.
So on an echo, this is actually good. The wall is actually going to look fairly gray, like a consistent gray. It's going to be more of a hypoechoic type of appearance, but you'll see kind of a little bit brighter line at the fluid side, and then the back side you'll see a bit of a line, and then you could see a bit of a space between this, and then you're going to see a thick white line beyond that. That's the pericardium. Never measure into the pericardium because then you're past the heart.
So left ventricular pericardial wall, diastole.
This is left ventricular posterior wall, diastole.
And so, is this where we use like the calipers and it just hits all of them? We just click?
Yes.
And continue to click down?
Correct. So it depends on the system. So like the Sonos 5500s, they cascade, meaning that when you do one caliper, it automatically jumps to the next one. So I don't have to reset this spot, I just have to set the next caliper. Whereas the GEs, you actually set that, and then you get a new caliper and set it there, and then a new caliper set there, and then there. So each system operates slightly different, and we'll kind of work with you as we go through the lab on that. But we're looking for this measurement, these two, the walls, they should be relatively the same. So they're going to be within about 1 millimeter of each other usually, but they need to be less than 10 millimeters in thickness. If they're more than that, you have a pathology. If they're less than 6 millimeters, you have a pathology. So the normal is basically 7 to 10 millimeters. They are slightly different for women and men. There are all kinds of charts and stuff, and they divvy them out by gender, but they also divvy them out by race. Okay, so there's tons and tons of charts, but we'll try to keep it, fairly broad. Where does it go with that? Oh, and then the chamber, we're looking about 5.5 to about 5.7 centimeters in diameter. Okay, I don't have the exact numbers anymore in my head, but when you're scanning, you'll typically have charts that you'll go by, and you'll get to know that really quick, and you'll know that. So after we do the diastolic measurement, so this is the end of diastole on the R wave, then we go to the next spot here. We scroll forward. The heart's now going to squeeze, so the chamber's going to get smaller, and the walls are going to get thicker, and we're going to go to the very end of the T wave. Okay? So if you're doing this visually, because me and Tammy both actually do this visually before we even look at the EKG. I actually don't even look at the EKG. I scroll this back and forth until the LV is as big as it can be. Okay, I'm scrolling back and forth until it starts going out, and then you scroll forward and then it starts going in, then I back it up until it's big again. I take it to its biggest diameter, which happens to always correlate to the end of diastole. End of systole, I go in until the walls are squeezed down as much as they can, and then it starts going out, and then I scroll back until it's back to that thinnest, smallest volume. So at the end of the T wave is where that's going to be. So you could either line it up to the T wave, or you can just do it visually like I do, and Tammy does also. So it's all the same measurements now, except now these are, instead of little d, it's little s for systole. So you're measuring both walls. You're going to measure the diameter of the chamber as well. Again, you can measure the RV, but that's only in diastole. And it's just measuring from, this is the right ventricular free wall, we're going to measure from there to whatever you see there. It's a horrible measurement, honestly, because the RV shapes around the LV, and it's very inconsistent, so it can throw your data if you're looking just at that alone. So there's actually a better way to do measurements on that now. Any questions on that? Okay. So we are also going to do M mode. So what is M mode? It's motion mode. Good. How does motion mode work? Now that my image is a total mess. So I'm taking a single, so the same line, so if I got my transducer up here, and I've got that same line through that same spot, I'm basically taking this line of information and I'm dragging it over time. Only that line of information. So what do I have here? I've got some RV right there. So we'll start with RV. I've got a chamber, so that's a space. Then I get my septal wall, a little bit thicker maybe. And then I get my space, and then I get my posterior wall. Okay? And then beyond that, then I'm going to have that, it's not going to be in different colors obviously, but that's where my pericardium is going to be. So that's what I'm going to see throughout my image. Now I'm going to be dragging it over time. So what happens to the ventricles as I go from diastole to systole? Okay, they're going to change. So first of all, you get the idea on the RV. I'm just going to leave that the way it is. It would go all the way across. What I'm going to do here is do a little, what it actually looks like. Okay, so it goes into there, and then it goes like this. Here, well, it's not quite as dramatic as that. Hold on. Okay, probably over dramatized a little bit, but you'll get the idea. So with this, as I talked about, so the ventricle comes in, it's got that early ejection, it's got the volume in there, and then I get the atrial kick, which gives a little bit extra volume. Just before the contraction, there's always a little extra volume if they're not in AFib, but that's still where the biggest volume is just before contraction. So we're going to measure the same stuff. So we're going to measure septal wall, we're going to measure the LV chamber, and we're going to measure the posterior wall. In diastole, and then also the same thing in systole. So I want to know how much they thicken, how big the chamber is, and that residual volume, and that's systole. Same thing as here. And if I'm doing this accurately and I'm doing it in the same place, technically my measurements should come out almost exactly the same. So if you're noticing a big difference between these measurements and those measurements in 2D, you're doing something wrong. Okay? Everybody get the concept of M mode? M mode can technically be done from long axis. I can also do it from short axis. It doesn't matter because all I'm looking at is that single ice pick single line of information. So if I twist it, as long as I'm in the center of what I'm looking at, I can do it either way, and that's perfectly acceptable.
And on the motion mode, it's still the top leading
Yes.
to the, on the bottom one, the top one as well.
Yeah, so leading edge to leading edge for everything. It's pretty much right on when you're looking at the walls. Good. So let's move from there up to the mitral valve. So there's one other M mode that we take. We do not do this in 2D, we only do this in M mode. We want to be perpendicular and hitting both mitral valve leaflets at the same time. So anterior leaflet and posterior leaflet. So that line is coming right through here, through the tips of that leaflet. I'll redraw those leaflets. So I want to see that and through that. Okay? So what do I see on M mode continuing on? So I've just slid this beam or tilted or rocked my transducer slightly to be able to hit that level because we're just past the tips of the leaflet. So now I'm going to see kind of the walls and stuff. They'll keep coming in as they do. Go along, kind of comes out, dips down, whatever. You're still going to see that. Okay, the same as before. But now inside here, we're going to get onto the, so this is systole, diastole is the big section in here. When does the mitral valve open? Not during systole. It's diastole, right? So early on it opens, so after this finishes contracting here, you'll get a closure line of the mitral valve tips will be closed together through this area. And then you're going to get, and that'll actually be kind of further back, it'll be more like back here. And then you're going to see E wave. And I'm going to look at to see both leaflets, the posterior and the anterior. They go opposite of each other because they're going in opposite directions, ideally. And then I've got my M mode there. So well, this goes more, it's wider than this because it has to go all the way through diastole to this atrial kick. So it would be wider. But then we're going to measure on this the what's called the EPSS. Okay? That stands for E point septal separation. What does that mean? It takes the point of my E wave right here, I put a caliper on that, and I put a caliper on the septal wall, and I'm looking at the distance between that. That needs to be less than 7 millimeters.
Can you show, where is that?
7 or less.
Again? Sorry.
So it's at the very tip of the E wave.
Okay.
So I'm looking at the anterior mitral valve leaflet, how close is it coming to the septum? And then I'm measuring the distance from the septum, that's all it is, EPSS.
And you'll actually see that on M mode?
Absolutely, yeah. So that's a very simple measurement, but that tells us some information that we'll talk about later, like how big the chamber might be, well, it's really looking at systolic function and how well the chambers, or how big the chamber is, how dilated it is. Simple measurement, it's not done in 2D, it's only done in M mode. Not all labs do it, but it's another tool for your tool belt, so to speak. Okay, so we've gone there, now we're going to go a little bit further on to, so there's 3 levels of M mode we take, so this is the first, this is second. Now the next one I want to go through the aortic valve tips. I'm going to redraw my aortic valve and sinuses of Valsalva so it looks better. I'm going to sort of over accentuate it a little bit here. Okay, so my aortic valve goes through here. It's got a coaptation, which means where the valve is shutting. That zona coapta is the area where the leaflets are touching together. So zona coapta is a name you want to be familiar with. That line goes right through those. It's perpendicular to that. It should be right at the tips. So I'm passing through some right ventricle. I'm passing through the aortic root, which is this, and sinuses of Valsalva, and it should technically be at the widest part of that. It goes through the tips of the leaflets and then through the left atria. Now ideally that's all lined up nicely. In reality it's never that clean. What does that look like on M mode? So I've got some right ventricle again. Gonna go through there. I've got the next interface is going to be just a line, a thin line, not like this thick muscular line here is. Then the next one is another line, which represents what? So that's my valve, the aortic valve tips. It's got both the right coronary cusp and the non-coronary cusp together right here. They're going to separate when it opens. Okay, we're going to see a box form with that. The next line is the back side of the aortic root. And then the next line is the back of the left atrial wall. So timing-wise, what are we looking at? So usually we get some up and down motion. I'm going to draw the boxes and stuff in here because it's easier for me to do it. Oops, this should be going up. Okay, and then my aortic root, this wall is going to be coming down. It goes up, and then down, and then up, and then down. Okay, so you see that the aortic root, as the heart beats, is going up and down with the motion because of all the contractions and stuff going on. It's being pulled in those different ways. And then we've got atria, okay, which kind of goes opposite of these. So the timing of these is going to be important. On top here, we've got the right ventricle that you'll see kind of all along the top there. So that's what we're going to see on the M mode through these valve levels. Now we measure these in 2D also. So we're going to measure aortic root is going to be at end diastole, and the LA, which is going to be from there to there, is going to be at end of systole. Okay? Because end of systole is when this is biggest, and then this is done at end of diastole when you would measure the diastole of the walls. So you could do the walls and the aortic root in the same one, and you could do systole and the left atria at the same time as well in 2D.
And those are 2D?
So these will be in 2D. We're going to measure the left atrial size in 2D. You want the maximum perpendicular size of that diameter of that chamber. And then you want across the aortic root here. Let's do that in red. So aortic root is going to be leading edge to leading edge across here. And diastole, left atria is going to be perpendicular across the chamber direction. Leading edge from inside of the aortic root actually to the first wall of the posterior LA. Okay, same measurements we're doing in M mode. We're going to do exactly the same thing. So these are going to look like this. So we're going to do leading edge to leading edge. So aortic root is this. You're going to do it in the biggest dip. Okay, so where this aortic root takes the biggest dip, which is going to correspond to my R wave. Okay. Then I'm going to measure the aortic cusp separation. So this is so aortic root. Next one's going to be cusp separation. This one we do inner to inner because we want to see how far did they separate. So this is my right coronary cusp. That's my non-coronary cusp. We do inner right at the beginning of the cycle. And vertical, I want to measure the space that it opens. This tells me if a valve is opening properly or if it's stenotic. So that is what we call ACS, or aortic cusp separation. Okay, and then my LA, I want to measure the left atrium when it's its biggest. When is it the biggest?
Systole.
So at the end of systole, so we got T wave. Okay, so it's going to be right at the end of the T wave for this, and it's going to be at the widest portion. Leading edge to leading edge. So we're going to get these three measurements on that M mode. Okay, again, these can all be done from short axis as well. It doesn't have to be done just at long axis. So what we do is we typically get a parasternal long axis view. You'll put the cursor through, you'll take it at the LV, you'll take it at the fish mouth or the tips of the mitral valve leaflets, and then you move it to the aortic root through the aortic valve in LA, okay? If I go in short axis, instead of moving my line, I can actually just sweep down. So you can do it either way, and it helps you to make sure that you're right in the center of it. In these measurements, we're going to exclude, especially in the walls, we're going to exclude papillary muscles. So if you see papillary muscles come in, you ignore the papillary muscles for the measurement. So that might look like, you know, having some, you know, tissue kind of in here. You might see some chordae tendineae. You want to measure to the actual wall and ignore the papillary muscles. Same thing on 2D. If you see papillary muscles in there, go behind the papillary muscles and do not include them. Otherwise, your wall is going to look really thick.
Can you just real quick go over what those were one more time?
So this is aortic root. So that's this moving up and down. You measure it at its lowest point, which is going to line up with the R wave of the QRS. Okay, then my aortic cusps are together here. This is where they're closed. And then early systole, when the box opens, this is the only one that we really measure in early systole. You don't want to do the end because the biggest volume going through the aortic valve is early. So you measure that right at the beginning of that box. Okay, you're looking at the cusp separation on that. And then the left atria, you're going to see when it's the biggest. We want to measure the chamber size when it's biggest.
Oh, and that, okay, that's the
Okay.
left atrium.
Yes. Yeah, sorry, I didn't label left atrium. Good. That's our M modes of parasternal long axis. We haven't even left the first view yet. Isn't it great? Honestly, a lot of what we do is right off that very first view. The rest of it is not quite as bad. What should we Doppler, do you think, on this? So we've done now our clip, and now we've finished our measurements, and we've done our M modes in 2D. That's all we've done. What do we do next? So we do 2D, we do the measurements, we do color Doppler. Okay? So what can I do on color Doppler? Let me redraw this because it's a mess. So we talked about structures that we want to look at. And what are those?
Valves.
So we got the chambers. And we got valves, right? So when we're looking at color Doppler, what do you think we're more interested in at this point? Valves. Okay, so let's draw our color box. So what's important on the valves, let's draw the valves in. We're going to look at aortic valve and mitral valve. They're right close together. We're going to zoom in first. Okay, so we've got our overall perspective. I want to see the walls of the valves because I need to see if there's any holes where there shouldn't be. And I also need to see the valves themselves to see if there's flow getting through it or if it's leaking back. So my color box is going to look something, or my region of interest box, the ROI, is going to look something like that. So include a little bit of right ventricle. I don't need the rest of it though. It's going to be narrow enough to cover both of my valves. I need to see both of those, and I need to see a little bit past them because if there's a leak or a jet, I need to see where that jet is going. I don't want to cut it off right at the tips. And then you want to see a bit of the posterior wall. So you want to see the structure you're interested in plus a little extra, and that's all you need. Okay, so we're going to zoom into that, and then we're going to stick on color. We use the BART protocol, so blue away, red towards. So here's my color bar indicator on this side. Just for the sake of completeness. Our scale on this is usually like mid-60s to about mid-80s-ish. And if I see leaky valves, it's going to be typically blue away, jet going back into the mitral that way, or I guess these will both be in blue because it's going to come back this way out of the aorta. They actually get blue and red because they alias a lot, and it's going to be look kind of a mixture of stuff there. But that's what I'm looking at. I'm looking at these, but I'm also looking for holes in the wall and just the fact that things are intact and that we don't have masses and tumors and vegetations hanging off the valves and stuff like that. So we'll take a 2D clip of this zoomed image, and then we'll take a color clip of this zoomed image. Do you think we can Doppler this, spectral Doppler? No, why?
The angle.
Okay, very poor angle, so we don't spectral Doppler this. So now we've done our 2D clip, we've done our 2D measurements, scrolling and freezing in the right places. We've done our M modes, now we're doing this. That's all we need to do at this level. So now we're ready for the next view.
For the color Doppler, all we're looking for is just like the flow going through the valves.
Correct, and if it's going across the walls. It should not cross the walls. Like if you had like a ventricular septal defect, for example, it would show up there, potentially. Or other things that are going on. So you want to throw the color Doppler on as kind of a generalized what's going on in this area, get an idea of what the hemodynamics is really doing. So that's that view. The next view we go into is the tricuspid valve. That one we simply do we don't need to measure anything in 2D, so we take a 2D clip, then we take a 2D in color, looking for leakages in the valve. Okay, that is, remember, tricuspid valve points up into the ventricle. So we're looking for regurgitations here. They would show up in blue because they're going away from the transducer. And honestly, if there's tricuspid stenosis, we'll take a look at it, but honestly, we don't care that much about it because it's not common. It's a lot more common in the mitral valve, but not so much here. But tricuspid valve regurgitation, everybody has. And what we're going to do is we're going to line that up at a 0-degree angle and get our spectral Doppler, which is going to look like this, baseline. This is, which direction is that jet going, away or towards the transducer? It's away from. So I want the spectral baseline near the top, and then I'm going to be looking for a waveform something like this. It's going to be kind of hazy, and we're going to measure the maximum velocity of it there. So this is called the TR max.
Why isn't it going towards?
Because the flow is coming from the atria to the ventricle. The normal flow is going in that way. We're looking for regurgitation when the valve's shut. So this is now squeezing and it's leaking back.
Okay.
If we looked at the inflow, we'd be on that side of the valve and we would see, like the mitral valve, an E and an A wave.
And you said this was PW Doppler?
Continuous wave.
Oh, we're doing, okay.
So it is CW. I didn't mention that, but thanks. Why would we use continuous wave Doppler? What's the advantage?
To get the highest velocity.
Right. So this is about 2 to 4 meters per second, which is very fast. That's 200 to 400 centimeters per second. These are consistently that high. If you don't have your scale set right, you're going to completely miss this. These velocities are going to be, relatively speaking, like 80 centimeters per second, or 0.8 meters per second. So relatively speaking, these are like 4 times faster. So if your scale's not right, if your scale's set up for something like this, you're going to miss this. Okay, it's going to be important to catch. So that's CW. Let's do pulmonary valve next. So that's all we need through that valve. Pulmonary valve, again, points away from the transducer, or away from the ventricle. The leaks on this valve, again, pulmonary stenosis is also rare, so we don't look at that often, but we do take Dopplers through it fairly regularly. You're going to get what's called a candle flame, so it looks like a little candle. On a regurgitation, it's going to be red, because now it's coming towards my transducer. The line is going to go through it. We're going to first take a sample in the RVOT. And that is going to look like this. Pulsed wave. It's going to be enveloped. So this is my Doppler signal. And on this one, we're looking for how fast does that come into there. So we're going to measure at the baseline to the peak. And we're going to look at the acceleration time, how fast that takes to do that. So what we're actually interested in here is the time that occurs. Okay, so that's acceleration time. This is actually in the RVOT. And then the next one we do is we throw a continuous wave through here. And now we're going to see the maximum flow through that area. So let me erase all this. Now it just came from 2 to 4 centimeters per, or 2 to 4 meters per second. Pulsed wave has envelopes. So we got the center of this should be dark and black. Whereas continuous wave is catching all flows, so you're going to get more of a fill-in. It's not going to be that big, long jet like the TR jet was, okay, like this. It's going to be lower velocity, again around 80 centimeters per second, or 0.8 meters per second. And we're going to measure, again, the maximum velocity of that. So this one we do an acceleration time before the valve. Then we take off the gate and we just go through the valve with continuous wave Doppler. You're going to put that kind of through the tip of the valve, and you're going to measure the peak velocity of that. So everything we do on Dopplers we'll talk about in physics. You want to optimize your spectral settings so that we minimize the room for error for measurements. Okay? And just for kicks, what does it look like on the regurgitation if I'm doing a CW through that? We are interested in the flow through the valve for this one. We're less interested in the regurgitation. But if you're going to see it, it's going to be like this. It's going to be a higher velocity. So it's just a leakiness coming back. It kind of goes up and then it goes kind of trapezoid almost and then drops back down. On the pulmonary, we do get a little bit of a kick at the end. For whatever reason we get that, and it's just characteristic of it. Aortic valve is going to look the same except without that.
Okay, so we do both PW and CW on this.
On pulmonary valve, yes. Good. We done? Ready? We're not even close. So we're on, we got our first 3 views done.
Can we take like a quick time out?
Yeah, we need to take a quick time out anyway because it's time for physics soon. So if you want after physics, maybe we can go over some more of this
Is this all going to be on our
I'm going to try to record it too. Maybe I'll probably go through it faster anyway if we're not lecturing while we do it.
Is this all going to be on our test next week?
Yes. Oh, there was